Welcome back. We're going to start this second segment. We're going to talk about working with data repositories. Um, you can call them data repositories, again, data warehouses, uh, EDWs. Doesn't matter what the terminology that you decide to use, but we're all going to get to the same. It's going to drive us to the same end result. And when it comes to working with data repositories, especially if you're working with um, a new data repository, let's say, or you're working with a company, let's say you're working with a health plan, it's a small health plan, and you've never really had um, a in-house data repository. You've always farmed it out to some other data management group, and you decide you want to bring it back in-house. And one of the first things that the health plan will do, or the payer will do, is they will develop a high-level business champion to engage all the stakeholders. And when we're talking about engaging all the stakeholders, you're talking about reaching out to anybody in that organization that might have a need, either currently or somewhere down the road, a need to access data out of your data repository, whatever that type of data repository happens to be. Uh, and also, when it comes to building these data repositories, your champion, um, a lot of times the champion, at least in the health plans I've worked with or worked for, the champion is, and there may not only be one champion, but a lot of times the champion is somebody that's more in on the business side of the house. Maybe somebody reporting up to the CFO or somebody reporting up to the chief actuary. Those tend to be those, at least from the functional area aspect. And then you've always going to have somebody on kind of the IT side of the house because they're going to handle the brunt of the workload. They're going to be responsible of taking the type of information that's identified by the functional area. We'll call them the functional areas in the corporation or the organization, and they're going to assimilate it and put it together. So you've got to have that buy-in, and you've always got to treat it as an ongoing system, as kind of a living, breathing, growing system, because as you move out over time, you're going to identify more and more pieces of data, pieces of information that certain functional areas within the organization have deemed necessary to be successful in managing the day-to-day business. One thing that you can do is you can hire experts to build and maintain the data repository, especially if you're a small health plan, especially if you're a small health plan. Let's say you've got a couple of 100,000 members. You may just hire the experts to build it, manage it, and you're off and running with it. Most of the health plans I work for have been large enough that they've got their own IT shop, they've got their own data warehouse, and it's always been managed internally. You have to keep the scope modest in the beginning because you want to build a return on the investment for the users. If you keep it modest in the beginning and get everybody comfortable in using it, then it's easier for them to see the return on investment that they can glean from using this information that's going to come out of the data repositories. They need to understand that the information in there has been sanitized, it's been checked for errors, it's gone through data governance, and it is as accurate as possibly can be, and they will be comfortable in using that information to drive their management decisions. Um, you'll hear people talk about ETL, and it's the extract transformation load to migrate data from one source to the next and to ensure the quality of the data going into that information warehouse. Because you hear people talk, and it's really a technical term, and they talk about junk in, junk out, and that's what you want to avoid. Um, I've already called other things too, but I'm probably not going to mention it on this video. But again, if you've got junk coming in, you're going to have junk coming out the other side because that that warehouse and all the programming that goes into it, remember, you've got data coming in, stored in the warehouse. People are playing with it, running programs on it, using software packages. They may be using SAS, they may be using business objects, a multitude of extraction type analytical programs, and they're going to end up putting out results that they will take and forward on to functional areas that are going to utilize that information in their decision making processes. So you want to ensure the data quality and whatever it takes to ensure that data quality. As you go forward in this, the data repositories, you want to build a base data repository, and then from that base data repository, you want to start putting out maybe data marts, or you may want to start, worrying about it, identifying your metadata that you've got out there. But you build the base repository, and then you start expanding it. You remember we talked earlier. We talked about data marts and data cubes. Great way to get people comfortable, especially in functional areas that may not be hardcore programmers. Functional areas, especially you can get data extraction software that's drag and drop. So you can have, this information set up for functional areas, and they know that if they're running this particular program, they need 3 pieces of data. So it's drag and drop. It makes it really simple for them. So as you're building this, the data repositories and then the data marts, you're also using the metadata. You want to get people comfortable with using it. People comfortable with using it, generating information, generating reports, and being comfortable enough in the data that they can go to their senior managers and provide insight into the strategic vision of that particular functional area. When you're also working with data repositories, you want to develop a data load timeline. Depending on, if it's a provider file, if it's a, the listing of your providers, maybe you only update that provider file once a month. If you're looking at paid claims information, you may be uploading it in the data warehouse at midnight every night. Maybe you upload a new file from starting at midnight, and it finishes running at 4 o'clock in the morning. So you've got to load your data timelines. You have to also develop training and education programs. You have to have people that understand the format of the data in that information warehouse, or in that data warehouse. Because if they're in there playing in that data warehouse, if they're in there running programs on that data warehouse, they have to understand. We talked earlier about data governance and data dictionary. They have to understand that process. They have to understand how to read that data dictionary. If it's dollar values, they need to understand it hadn't been rounded to the nearest dollar. It's going to have a decimal point and 2 placeholders out by it. If it's provider name, they need to know its first name, last name, and then if there's any like Dr., Mr., Mrs. assigned to it. They have to understand the format of birthdays. Just a lot of information through training and education programs, because you don't want individuals trying to generate reports out of a data warehouse or an information warehouse that is going to be used to develop policies and procedures for a functional area if they don't understand what they're doing, if they don't understand the data that they pull. I can remember when I first started in healthcare years ago, and I can't remember what we were, and it was in Southern California, and we were talking about, I think, hospitals. And I, asked them, we need to know that, by hospital, how much is it costing for, certain diagnosis related groups or certain types of discharges. And I think we were looking at cardiac types of discharges. And I think, somebody reached out to us and said, how do we determine what an equitable rate was for the heart transplant? So, they're in there pulling, I had somebody, I signed it to them, the individual came back and, it's like, you know, he had, here's what it cost us. And, he's looking, I'm looking at it, and it's like, it's average like, $2 million. And I'm thinking, this just can't be right. And the more I delved into it, the individual had gone in and in the information warehouse we had bill charges, we had allowed charges, which is what was allowed by the contract. So billed is what the provider billed, allowed was allowed by the contract. We had the member copay, co-insurance, the member's responsibility, and then you had the paid amount. Okay, I wanted the paid amount, and I specifically sat down and talked to this individual. I said, you need to give me the paid amount. That's what the health plan is on the hook for, the paid amount. They'd gotten confused. They'd gone into the information where they'd pulled the bill amount. I mean, it took us 10 minutes to figure out the issue. But if that had gone up to the CFO or the CEO, there were a lot of us that would have been in a world of hurt. So you just have to develop these training and education programs so that individuals working in that information warehouse or in that data repository know how to extract the information. They know how to array it in such a way that they can explain it and have accurate, defined, defensible results. And then lastly, you have to have a development expansion strategy, technological flexibility, because I have never worked in a health plan where the format of the information warehouse was sufficient. It doesn't matter. You set up a format, the thing has to be scalable. You have to have an expansion strategy, because whatever the size that you think you're going to need, I will guarantee you it's going to be more than you could ever imagine. And you run into that a lot with health plans. I want to talk a few minutes about, again, we're talking about on this, we're talking about payer files. And when the next set of slides that we'll talk about when we get to the provider side, it's going to be a different type of informational files, and because they're utilized differently. But on the payer information files, you've got they drive things like pre-adjudication decisions. They drive the adjudication, and when I talk about adjudication, it's paying the claim. When you hear people talk about, well, we adjudicated that claim, well, they processed the claim and they paid the claim. So that's the adjudication process. So you've got pre-adjudication, you've got the adjudication process where the claim runs through the system, it's processed, it's, the payment's calculated, and it goes into a holding area, and then eventually goes out the door to the provider. And then you've got post-adjudication, kind of the environment where you're doing audits, you're playing around in the data, you're making sure that the claims are processing correctly. So when it comes to payer informational files, we're going to talk for a few minutes about just the types of files. And the first one that we'll talk about is a provider file. It's a file that it's one of the, I guess you kind of claim it the big three. Typically in a health plan, the big three files are provider files, member files, and claims files. And so the provider file is going to have all of your provider information. It could have Dr. John Smith, MD, DO, PhD, maybe it's a psychologist. It's going to have information, maybe it's going to have address information, going to have birth dates. It's going to have, may have where, the provider went to school. It's going to have information in that provider file that talks about office locations, how many office locations they have, what the provider tax ID is, how it's billed. Do they have more than one specialty? If it's a primary care doctor, is he board certified in internal medicine? Then maybe so it's got a secondary board certification in cardiology. It's got all of this type of information, board certifications, where they can practice, what states they can practice in, information that pertains to the provider themselves. And then you've got the member file. You've got member file. It's got name. It's got dates. It's got addresses. It's got information on who is it the member, and is it the responsible party? So just like when I worked at HealthNet in Southern California, I worked at HealthNet. My wife was a consultant, and my son was still in high school. So I'm the responsible party. I'm the member at HealthNet. I get my health insurance through HealthNet. On my health plan, though, is also my wife and my son. And so I'm the responsible party. But if my wife goes to see the doctor, my wife's going to be the member. My son goes to the doctor, he's going to be the member. But I'm still going to be the responsible party that's going to pay for those healthcare goods and services. And that's what you're going to find in the member file. You're going to find my address. You're going to find her address. And my wife, because she was a consultant, worked a lot of the time away from home. She's, even when I worked in Buffalo for Blue Cross Blue Shield, she spent some time in Las Vegas working with a health plan. She spent some time in Indianapolis. When we were in Southern California and I worked at HealthNet, my son was, in high school, he was still under my health plan. When he went to University of Pennsylvania to college, and he's on my health plan, and he has emergency appendectomy while he's in college, and so he's on my health plan, and so I'm the responsible party. So this is the type of information that's going to be in these member files: is who's going to be responsible for paying for healthcare goods and services for everybody listed as a beneficiary under my responsible party, under me as the responsible party. So it's going to have birthdays, it's going to have addresses, anything that's needed to ensure that claim. And you'll hear people talk about adjudicating a claim, and that's just processing the claim and paying for it. So it's individual, it's information in the provider file in conjunction with information in the member file that's going to ensure accurate adjudication of a healthcare claim. And so provider files, member files, those two come together as the claim comes into the system, and the result goes into the claim file. So claim comes in, let's say claim came in for my son. Claim comes in for my son. It's going to look at me as a responsible party. It's going to look at my health plan. It's going to look at the benefits that's under my health plan, and the benefits are going to be in your member file. That's going to tell the claim system what type of benefit plan do you have. Did I have a HMO? Did I have a PPO? Did I have a private pay? It's going to tell the system how to pay that claim. Information in the member file, so that claims coming in, it's going to access the member file. It's going to access mine as the responsible party, even though my son may have had to go to the doctor, played football at the University of Pennsylvania, so it was not out of the ordinary for him to see a doctor for an ankle sprain or something. So he's that's the way the system's going to look at it. That claim's going to come through the system. It's going to adjudicate, or it's going to pay. It's going to adjudicate, process, and eventually pay. Payment goes from Health Med in Southern California. Actually, the office was in Sacramento, but it'll go from Health Med, and it'll shoot out the door, and it went back to the provider in Philadelphia. And so the provider is paid, and that information then is captured in these claim files. Any type of healthcare good or service that generates a payment is going to be captured in the claim files. It's going to show me as the responsible party. It's going to, but it may have a claim for my wife, may have a claim for my son, may have a claim for myself, but it's going to show me as a responsible party. It's going to be captured in that claim file. And in that claim file, go back to all of those boxes that we talked about on the CMS 1500, the UB04, the UB04, the CMS 1495. Go back to those boxes on those claim forms that we talked about, and that's going to be the information that's captured in that claim file. Information from those claim forms captured in the claim file, plus payment information. And so a tremendous amount of information captured in that claim file. Another set of payer informational files that is going to be stored in our information warehouse for the most part, you're going to have government files. If you work for a health plan that has Medicare Advantage or over 65 population type, senior type claims, it's going to have government files in there with government information about a senior population. If you work for a health plan that has a Medicaid population, it's going to have information from these government files in there based on Medicaid information. Government files can have a lot of information within these government files, either federal government files or state government files, or maybe even some local government files. There's going to be stored in there in these government files, and the information out of those files will be utilized to ensure that that claim is what they call adjudicated. When the claim adjudicates, it means the claim processes and pays. So there's going to be a lot of information from these government files that may or may not be utilized to accurately pay that claim as it flows through the system. As far as the payer information files, you may have what you call consultant files or vendor files. Payment integrity is a area within most health plans. May not be called payment integrity, may be called internal audit or something, but it is a area within a health plan that ensures that the claim pays accurately. And a lot of health plans don't have the, I'm going to say the bandwidth. They don't have the financial wherewithal to hire all of the professionals that they need. And to supplement what they have internally, they use what's called healthcare vendors to provide services to ensure claims are paying correctly. They may hire consultants. They may hire vendors. They're hiring outside or external expertise to help the health plan ensure that the claims are paying accurately. And within this information warehouse, you can have a lot of these vendor files. You can have a lot of these consultant files that are feeding into the information warehouse that ensures that the information is accurate within that information warehouse. You have a group of files within Blue Cross Blue Shield and I was the director of the accuracy group, the payment integrity team. I had what they call a coordination of benefit team that worked for me. And your coordination of benefit files, it's a specific group of files that they deal with MVAs, motor vehicle accidents. They're the responsible teams coordinating benefits on motor vehicle accidents. Was it your fault? Was it the other driver's fault? Was it a no fault? State of New York had no fault insurance. They have workers' comp. Workers' comp is a coordination of benefits. You're coordinating the benefits between health plans and a workers' comp claim. They have subrogation. You have a member that slips in. You have a member in the, and I know it sounds weird, but I have seen these types of claims. You have a member that goes into Walmart. They are walking back through the produce department. They slip. There's somebody's dropped some grapes on the floor. They slip on the grapes and they tear up a knee. That's a subrogatable. That the responsibility for paying those healthcare claims should fall on Walmart. And that's what coordination of benefit files do. They ensure that the responsible party pays for those healthcare goods and services that are consumed. You have mass tort. Mass tort is where you get into a situation where, let's say you had a hip replacement, and they put a hip in that was defective. So you've got mass tort type situations. You've got negative balance situations, and the coordination of benefits takes care of this too. Negative balance is when you have a situation set up where you've overpaid a provider. And rather than taking the money back from the provider, you set up a negative balance. Let's say you've overpaid the provider. It's a hospital. You've overpaid them $1,000. You set up what's called a negative balance in the system of $1,000. And as claims come in from that provider, you will not pay any more claims until that $1,000 is met and erased off the books. You have member paid insurance. Member provides you incorrect or inaccurate information, either inadvertently or on purpose. And the on purpose aspect happens a lot. They provide information that's inaccurate, and you pay the member too much, and you have to set up a negative balance in there on the member. So as the member continues to see healthcare goods or receive healthcare goods and services, that goes against that negative balance that is set up against the member paid. So and also within coordination of benefit, let's say that you're a married couple, and let me think, you're a married couple and one of you works for Fisk University and covered on a health plan on Fisk University. The other one works for Meharry Medical Center. Two different health plans, two different responsibilities. One of one of you that works for Meharry Health Plan, maybe they have their health insurance through United Health Plans. One that works for Fisk University, let's say they have their information through their health plan is through Tennessee Blue Cross Blue Shield Tennessee. And so when the claim comes in, you have to determine who's the responsible party. That's what you're talking about, coordinating benefits. Same thing if you are Medicare eligible and you are working, you're still working, so you're over 65, you're Medicare eligible, you're still working, those claims come in, the health plan has to take and determine and coordinate those benefits between Medicare and the company that you work for. So you've got all of these coordination of benefit files floating around in there, and members of a health plan either purposely or inadvertently withhold information especially when it comes to coverage details. And coordination of benefits, that is the responsibility of the coordination of benefits teams. They are coordinating those benefits. They're trying to figure out, let me see, let's say you work for an organization and you slip and fall at work, tear up your knee. Happened at work, should be workers' compensation. You don't declare workers' compensation, or your company doesn't declare workers' compensation. The claim comes in, the health plan, before they pay it, they may look at it and say, this individual's got a banged up knee. First thing they say is, wonder if it happened at work. And that's where you start coordinating benefits. So a coordination of benefits team is an extremely important area to work in. And it's really an interesting area to work in. You'd be surprised, especially with motor vehicle accidents, and subrogation type accidents where, you fall at work and you don't want the health plan to know that, or you fell at Walmart. You don't want the health plan to know that Walmart's going to pay you some money, because you don't want the health plan to get in that money. You want the health plan to pay for services. So things get a little shady when it comes to coordination of benefits. Supplemental files. You have a lot of supplemental files out there. You have legal files. You have internal audit. You have provider documents that you may store in an information warehouse, or at least in a repository. You've got contractual information, both hospital contracts, medical provider contracts, ambi-surge, got a lot of contractual information that's stored because that information has to be utilized to pay the claims. You've got policies and procedures that are stored out there. You've got dashboards. There are a lot of information in this information warehouse, or especially in these informational files on the payer side, are driving these dashboards. And these dashboards are pre-programmed. You can get into them, play around with them. Let's say you're looking for particular information on a particular hospital as far as normal vaginal deliveries, or number of cardiac procedures. You can get into the dashboards and get that information by just clicking a few buttons. These dashboards will sit on top of these informational files in this information warehouse. You've got population health. If you're, if you're a diabetic or you're on the right diabetic medication, it's identifying these individuals that have comorbidities, is the terminology used. So these individuals that have these medical situations, and population health is trying to, on the health plan side, or on the payer side, they're trying, whichever terminology you want to use, they're trying to reach out to help these individuals lead a healthier, more active, fuller life, and to live a longer, healthier, active life. So that's where population health files come in. You've got case management. Case management, especially if you've gone to a hospital and you've had a cardiac procedure, you've had a hip replacement, a knee replacement. Case management may get in and help manage that case, may help you not only manage the cost of that case, but they may be managing the follow-up care, the care that you receive when you go home. And then you've got member outreach files that will show up in there, especially mailing files, member satisfaction type files, that type of information. So in the healthcare space, there's just a tremendous amount of informational files that are pulled together, stored in this information warehouse, and then extracted by different functional areas across the entire continuum of the health plan to manage the day-to-day business decisions of all the individuals covered by that health plan. And with that, we're going to stop for just a minute. And when we come back, we're going to talk about just information from, what you can get out of a information warehouse. Talk to you in a few minutes.